pericarditis. This is more likely to occur 2 to 3 days after an MI. So 2 to 3 days after the MI, they're still in the hospital. We're going to be looking for signs and symptoms of acute pericarditis. It's a common complication. It's diagnosed by EKG. I'm not exactly sure how they see that, but the cardiologist can look at that and actually tell. We can tell by actually oscillating for that pericardial friction rub. That's how we tell. Now, what about inflammation of distal and collateral pericardium? Results in cardiac compression with less ventricular filling and emptying. We may have some heart failure going on. Now, the chest pain here is different from their angina. The pain is on inspiration. They cough whenever they move their upper chest. Cough, sneeze, whatever. So you have to lean forward while sitting to relieve the pain. We treat this with aspirin, and they're going to be on aspirin daily anyway, post-MI, and corticosteroids decrease the inflammation. And this is pretty common. 2 to 3 days after MI, you may hear that friction rub when you're auscultating the chest wall. Now, Dressler's happens more like when they're at home, 4 to 6 weeks out after an MI. Oh, excuse me. Actually, you may have a slight fever. You can have a fever with acute pericarditis. You may have a fever. Not always. This is a possibility. Now, Dressler's is 4 to 6 weeks out after an MI. They're at home. And they usually have a fever and pleural effusion. It can happen after a cardiac surgery also, Dressler's. 4 to 6 weeks out after. An immune reaction to the necrotic myocardium, so that dead tissue is an immune reaction that causes that. You're going to have that pericardial chest pain. You're going to hear that friction rub when you auscultate. They have joint pain. They have an elevated white blood cell count, an elevated inflammatory marker called ESR, the erythrocyte sedimentation rate. ESR is an inflammatory marker. Erythrocyte sedimentation rate. It goes along with the joint pain and the elevated white blood cell count and inflammation. Treatment is corticosteroids. So corticosteroids is the treatment for Dressler's. Again, it's 4 to 6 weeks after cardiac surgery or an MI because of the irritated heart, dead tissue, inflammatory response. So with unstable angina and MI, we're going to get a detailed health history and physical, as usual. Our best evidence of ischemia or infarction will always be the EKG. We're going to look for changes in the QRS complex. The ST segment may be elevated or depressed. We'll look at that T wave. We're going to rule out or confirm a UA, unstable angina or an MI. Now, if an ST elevation is greater than 1 millimeter and more than 1 lead, this is when we look at the EKG. We've had an MI. Now, when we look at some EKGs here coming up, I'll show you what they're talking about. We're going to look at serum cardiac markers. Those are on page 728 of your text. We're more interested in components. On another slide, we'll talk about all 3 of them coming up. There's a diagram I want to go over. But we look at the components. They come out the earliest. They come out within an hour. They're least they come out within an hour to the bloodstream. And they leak those done. And they can also go to have an exercise stress test. We only do that if their troponins come back negative. If they have no heart damage, we'll take them to the stress lab for a stress test. Echocardiogram. So we can do that. But if they have positive troponins, we're going to go to the cath lab. We don't do a stress test because we already have a problem. Heart pump is damaged. And so the EKG tells us a lot. It tells about ischemia, ST depression, ST elevation, which is injury, infarction. And it also will tell us, we have a diagram coming up here shortly, how the changes go through with an evolving MI, how eventually the ST segment gets back down to normal. So that's the resolution of MI in that respect on EKG. So we do 0 EKGs with each episode of chest pain in the hospital. You just have a doctor's order for that. Here's an EKG. And someone made a good point this morning, like, it says sinus rhythm. You can't always rely on what it says. The machine reads this. We've had to say sinus rhythm patients have an active MI. So even though the machine spits out this interpretation, you have to know as a nurse what to look for. And all you're looking for is ST elevation or depression. Okay? And as we see here, I'm going to give you a brief overview of what they look at. Again, I learned this on the job and also from paramedic friends of mine. And I have a cardiac system and stuff like that. It's an ACLS. We learned a rhythm, so we don't learn EKG. EKG is a different class. I've had class for over the years, but I finally got a cheat sheet from a paramedic flight nurse. I just love it. It makes it so simple as a nurse to look at these. The paramedics are good. First of all, we looked at lead 2 and 3. So this lead 2, 3, I think I'm just showing you how we look at stuff to tell you what area is hard. Lead 2, 3, and ABS. So this right here, this here and here is the inferior portion of the heart. So we want to look at lead 2 first. Inferior portion. Most of mine happen in the inferior portion of the heart. Also, that's inferior. Anterior heart is B1, 2, 3, and 4. So B1, 2, 3, 4. This is anterior of the heart. This one, number 2, 2, 3, and AVF. And you don't have to memorize these guys. I'm just trying to help as a nurse. We're looking for ST elevation and depression in 2 different leads. But if you want to look at where in the heart is the region, it's kind of nice to know that too. But, you know, again, once you start working, you're going to pick this up quicker than here in the classroom. I'm reading the website. Here's this website online. I totally love it, you guys. Totally love it. No, I have a copy though. I'll post the website. Okay, I just love it. He makes it so simple. And that's what nurses need. They're on the job. You know what I mean? They're on the job. Because even at ACLS, we learn rhythm strips just by looking at them, but we don't learn EKG. That's a different class. I had one years ago, and I really learned nothing in it. Because he made it so simple. He's also a nurse. He's a nurse, an ER nurse, and a flight nurse. And he's a paramedic, so it makes a much difference. Now, so B1, 2, 3, and 4 is anterior heart. Now, the lateral, you're going to ask about posterior. And he says this very well, too. There's no need to tell us what's happening in the posterior part of the heart. If you look at the anterior, though, and you see ST elevation, I got my cheat sheet in my page there. But you can actually see what if you have a posterior MI. And I think in that one it's ST depression, if I remember. But anyway, it's just so cool to know how to do this at a glance once you memorize these. Oh yeah. Okay, yeah. ST depression. So there's ST elevation in B1, 2, 3, and 4 anterior. It's going to be an anterior MI. If it's ST depression in B1, 2, 3, and 4, those anterior leads, it's a posterior MI. So, and that's how he breaks this down. They break it down even further, but we just need to know the basics. And then also for the So those four tell us that's the lateral side of the heart. There is no ST elevation on this one here or the depression. But we go to the next one, it's a little bit obvious. We always look at lead two first. Inferior heart. There's a lead two always first is what we teach. ST elevation, look at that. It's more than 1 millimeter. 1 millimeter is just a slight increase above the baseline there. But look how that's elevated there. We also got it, and here's lead two all the way down here too. You can see a better picture. It's consistently elevated. See, look how high that one is. How high that one is. See, it should be coming back down to baseline. It doesn't. So, lead two, we have an inferior line for sure there. Now, if I look at, we also have, we have it here too. Lead six lateral, there's an elevation there, yeah. We have an anterolateral in line here, guys. Two, there's ST elevation or depression. This one here, look at lead two there first. Look at that. ST elevation. Lead three. ST elevation there. There's Demi. Here's lead two all the way down here too. I'm actually having all that at the bottom there on our EKGs. I'm just used to this here. Just very good consistently there. And then try to go back. So anyway, but you're looking for ST elevation or depression there. So here's another one. Lead two. Here's lead two all the way across down there. This is a different type of EKG. I'm not used to see that at the bottom there. All you need to know is elevation and depression. Okay? That's all you need to know as a nurse. And because I'm going to show you a picture. Here it is. This is how an MI evolves. When a patient comes in with chest pain, the first EKG might look pretty normal. Cardiac cycle there. The next one, grab your chest pain versus slight elevation there. I had a 40-year-old, 46 or something, come in with chest pain while fishing. Out of town. Had chest pain for an hour before he came in. I took his EKG. He was having a STEMI. Look at that elevation, how severe that is. I gave a lot of meds. I gave Plavix 300 milligrams by mouth. I prescribed him metoprolol. We put him on a heparin drip and on a nitro drip. Raised being about 5. We did a lot of stuff with him. Anyway, the doctor's in there talking to him because I already had an IV in with some help. And I did the EKG because the first thing we had to hook up stomach. The first time we do is hook up telemetry, right? Always. You get to know what's going on their heart rhythm when they have chest pain. And then I think the paramedics put an IV for me, and I was also doing the EKG. I grabbed the machine first. And then the doctor was there, of course. And I went to the doctor and said, here's the EKG. Let me know what message you want me to give right away to make you more comfortable. And that's why I handled it. So we had him flown out within 30 to 45 minutes. Didn't have to tap that day. So the doctor. Anyway, so this happens over hours to days, you guys. Eventually, it should get back to normal there, that ST segment. Okay? Look how it gets depressed with the ischemia right before that. I should go through this here. Down. That's evolution of acute MI. If we get to the cath lab during this time, so that was the point, that's why it's flown out, is we can limit the size of that infarction. The sooner we get to the cath lab. Now, this is the temporary marker. I saw several different diagrams, and this one's the older one. I think it's 2007. This is a textbook one. I mean, it's a company textbook for insight. But there were some other ones online I liked, but they weren't as good as this one. They weren't as clear, so I kept this one. And I do like this one. As you can see, we're going to talk about what comes out in the bloodstream after an MI, or serum cardiac marker. The first one's a troponin there. Troponin comes out within 1 hour. So it rises from our bloodstream within 1 hour. It comes out from those dead cardiac cells, or leaked out, or enzymes. Now they peak in 24 to 48 hours. They peak in 24 to 48 hours. But the level stays up in our bloodstream for about 5 to 14 days. So 5 to 14 days after the MI, we still have an elevated level of troponin. And that's good to know if a patient comes in and says, you know what, I had chest pain a week ago, it went away, I got this heartburn, I woke up this morning, it was the same thing, but you know what, it's getting worse and I'm scared to death. And you do that EKG, and if you see FC elevation or depression or whatever, you're still going to get those troponins, and troponins will show an increase because it's still within that time there. So troponins rise in 1 hour in our bloodstream, so they're first to come out, to get the blood level. They peak in 24 to 48 hours, and they're normally elevated for about 5 to 14 days. So for about 2 weeks, after the MI, we still see a little bit of elevation until they get back to not being less than 0.0, whatever our level is for normal. Now, the CKMB is specific, creatinine kinase, specific also for cell death, but it's slow to come out. It comes out in 3 to 6 hours. It peaks in 24 hours. And it normalizes back to normal levels in 2 to 3 days. So see why, again, why troponins are our best bet. And then the myoglobin shows up that it's non-specific. Can you repeat the CKMB? Yes. It rises in 3 to 6 hours. It peaks in 24 hours. And it normalizes in about 2 to 3 days back to a normal level. So myoglobin is non-specific. It comes right out like the troponin does. It's one of the first ones to come out, as you can see here. But what happens there is it's non-specific because it could be from kidney muscle damage. And the kidneys like to excrete it right away. The kidneys have it excreted within 24 hours. It's back to its normal level. So if we don't take the myoglobin that serious, in fact, cardiology now is saying, like I told you today, is why don't we just stick to troponins? Why do we waste our time on this? We do this old stuff, but this is our best bet. Here. And so that's been kind of new thing coming out. And actually, I was caught up on my reading over the weekend from Cardiovascular Weekly, and there's still 3 most taken ones. The EKG first, and then troponins. That's what we really need to know. That's our evidence. Okay, now emergency management. We're doing initial interventions. We always put them on a heart monitor first. When anybody comes in with heart pain, no matter where they're at, the clinic, the hospital, med-surg, ER, yeah, we put them on a heart monitor to see what the EKG show, heart rhythm is. Then we do our bone ups. So we have oxygen we apply next, and we just put on about 4 liters, 2 to 4 liters. A lot of times with ACLS, for heart attacks, we usually start out with 4 liters to get them more comfortable. The third thing we do is start IV if we don't have one in already. And then number 4, we're going to start doing our meds, our nitro, our aspirin, our morphine. And number 5, we're going to get those enzymes strong. So always heart monitor first, I want you to remember that. Always, we have number 4 on. When I say heart monitor, it means telemetry. So you get that EKG machine. So you want to get that EKG as soon as possible, but pop them on that monitor as soon as you can to that heart rhythm. You're going to see FC elevation if you're standing on that heart rhythm normally. You never want to leave them either. You're going to stick with them because they have a problem. And we do, don't we? We do that. And then, if they give it by animal, of course they have one animal, which is 12 days, but as soon as they hit the ER, one of us is doing that right away. Usually children's examination, we want an IV in each arm and everything for this client. And usually it's 2. And I guess one day I was really upset though, because the hospital about it. The Prevex heparin pure bags. I had to stop the Prevex and a heparin pure bag, which took about 8 minutes, you guys. I was mad because I had to check this in 2 RNs. 8 minutes. I pushed my ventilator off, gave my flag. You know, I had the nitro drip, pressing the zone. had this game they played between the cardiologists. Who was the winning cardiologist? Who had the best time of getting their clients to cath lab fast? They timed it in minutes. They put those in. The cardiologists all had game play. This would be kind of one of the ways up. But they were saving lives, bottom line, right, guys? So it's kind of fun that way. This manager was playing these games with cardiologists. Good things going. Now, hospital times usually 1 to 3 days. After any consuming certain, remember to have that stents put in. We talked about the other day. The stents put in, we're going to see a little bump in our troponins, aren't we? Because we're causing a little bit of damage to those arteries when we go in them with a stent due to the procedure. So, and those troponins should come down immediately. If they start climbing, then we have maybe a little bit more damage, and we keep them even an extra day. They're usually at least 24 to 48 hours after a stent procedure is done. Usually the longest. I had one guy for 3 days. It's just the ones that climb. See, we do those troponins. We do them like every 6 to 8 hours as ordered. So they usually order 3 sets. So the first one might be like 0.15. The second one might be in 6 hours might be 0.24. If the third one is going up and not coming down, we're going to keep doing them until they peak. And then the fourth and fifth one, when it comes down, then we'll stop doing them. Then we know it's safe to stop doing the troponin. So we actually know that tells us the extent of the heart damage. So if we get to the cath lab during the process, we're going to limit that heart damage anyway. There's always a slight chance of heart damage, always when you're putting a stent in or doing a cath procedure. So we're inside that artery. Now, a CABG, which we're going to talk about later today, hopefully, they're in the hospital at least 4 to 6 days. So, see, when you take care of it in the cath lab, get that stent in. Sometimes we can't get that stent in. We can't get that stent in. Or we get the stent in and they're starting to have chest pain again, and they reach the nose. The procedure didn't work. We have to get them to surgery for a CABG as soon as we can. So. All right, well, then therapy. Oh, one more thing here on the cath lab I want to mention here. So, in the cath lab, we locate those blocked arteries specifically, and then kind of talk about EKG, which part of the heart is having a problem. We're going to assess the severity of that blockage. We're going to check for any collateral circulation, and the cardiologist time for most of them. But we still stick with that. So, an indication is their chest pain has been less than or equal to 6 hours. If they had EKG changes, remember we only use thrombolytics, which are fibrolytics. We only use those if they have ST elevation. That means they have a STEMI. If it's a non-STEMI, we don't have the evidence of ST elevation. It's not there. So they say if we gave this, that would make that plaque more unstable. It could actually rupture and cause hemorrhage. And that could actually harm the patient more. The risk is too great. So you have to be a STEMI, actually. That's the elevation in line to give a fibrolytic. And that is the most current research. It hasn't changed on that part. But it's interesting that on some of the drugs now, they're given a longer window of time. So I think that's very interesting. So how do you know the reperfusion went well? We know because the ST segment went back to the baseline on that one picture we saw, on our graph. How it evolves. Look at F there. It's back to the baseline. It should happen there. But what else happens with fibrolytic reperfusion therapy? Remember Janet taught that in Acute Farm a couple terms ago, maybe, guys? Anybody remember? The heart gets really excited. The heart gets excited because it has more blood supply, more oxygen now. So what happens is we have these little dysrhythmias come up, like VTAC, and that we usually don't treat those with antiarrhythmic drugs. They're very short term. They might have a 5 or 6 week run of VTAC, and then it goes back to sinus rhythm. So we just watch it closely. They're in the ICU anyway. Now we both do a rescue PCI procedure for percutaneous intervention in cath lab if the thrombolytics don't work. Again, we're using thrombolytics and STEMI. Major complication is bleeding. So if they've had a history of GI bleeding or Peptic ulcers or anything like that, or a history of any aneurysm, we would never ever get it, would we? Because that wouldn't be safe. If they had a CVA in the past 3 months, if they had surgery in the past 3 months, we would not give it. And I don't know if you've been around anybody with the thrombolytics, but there's a little bit of blood leaking around the IV site, which is normal. They may have a little bit of blood oozing from their gums. That's normal. But if what we see as a complication is that we know they're bleeding by these signs and symptoms. If their heart rate goes up, the blood pressure drops, and they have a change in mental status, a level of consciousness, they start getting somnolent, hard to arouse or something, we may have a head bleed. We need to stop that infusion. If it's one we're infusing or one we're pushing, we stop it. On the signs and symptoms of low blood pressure, the bleeding, no history of GI bleeding. If they've had a stroke or surgery in the past 3 months, that would be a contraindication also not to give it.
And you know they're bleeding.
The heart rate goes up, the blood pressure drops, and they have a change in level of consciousness, like they get somnolent or hard to arouse. Or, yeah, and I've never seen that, but you have to consider a brain bleed at that. They have an aneurysm in their brain they didn't know about. So, now, Janet was telling me an interesting story last week. She said years ago they had somebody that met all the criteria. So they went ahead and gave the thrombolytic. I can't remember, I don't know if it's TPA or what, because it's TPA. Anyway, she said, wasn't very long, he started just really bleeding a lot from his mouth. And they asked him, and they were, icing and everything, they stopped the infusion, he's not had any, he had oral surgery 2 weeks before, forgot to tell him. Well, he was worried about his heart, not thinking he was in pain. So that Tridil, Tridil. In a glass bottle, we use benzene nitrotoluene, which is kind of a darker tube. Have you guys done any of this on clinicals or seen it in your ICUs? Or, nitro is a vasodilator. So it increases collateral circulation, blood flow. It should increase coronary artery blood flow specifically, so the peripheral and coronary. So that's important to remember. It should decrease your O2 demand, and it does decrease preload and afterload. And it should take the pain away. We do worry about lower blood pressures with nitro. So if you're on IV nitro, systolic blood pressure, this is a general universal rule, should be at least 100 systolic blood pressure. If it drops below 100 on your monitor, and you check it yourself manually, so you just don't take the monitor as being set in stone. We actually physically assess our patients too. If it's less than 100, like 98 or something, we have to turn that Tridil infusion down, titrate it down, or stop it, depending on the doctor's orders, okay? If they've been pain-free for a few hours, he may just say stop it. If he's still having pain, the doctor may say titrate it down to keep that blood pressure, blood pressure 100. Now morphine is given actually, because it's a vasodilator too, but sometimes when the pain doesn't go with nitro, we still go ahead and give morphine, and that's part of our protocol too. And again, it decreases, it's a vasodilator, so it decreases the workload of your heart. It also helps with anxiety and fear. But it's a vasodilator, and it should take away the pain, hopefully, that the nitro did. We have the beta-adrenergic blockers. Beta-adrenergic blockers are one of the first-line drugs for MI. They actually also help decrease the size of the MI. So they lower the blood pressure, they lower the heart rate, so they lower the workload of the heart. So that helps relieve some of the stress on the heart. They do actually affect preload and afterload. They decrease that also. And of course, they'll decrease myocardial contractility if they're adrenergic blockers. Now, the ACE inhibitors are next. If they don't tolerate the beta-adrenergic blockers, we'll give them an ACE inhibitor. But we do like ACE inhibitors anyway. We like ACE inhibitors. ACE inhibitors prevent ventricular remodeling. Remember when the good heart tissue then enlarges after an MI to kind of make up for all the damage that's going on there? Actually, and it can bring you to heart failure. Actually, ACE inhibitors are great for preventing that ventricular remodeling, and they also slow down the heart failure. So ACE inhibitors are good. If the patient has a history of heart failure, of course we're going to put them on an ACE inhibitor. They also said ACE inhibitors are good if the ejection fraction in a STEMI patient, the ST elevated MI patient, is less than or equal to 40%. The ACE inhibitors are more beneficial. So you get that point too. But also the physician looks at the client themselves, right? Every one of us is different. I have asthma. They probably wouldn't put me on a beta blocker. Probably not. They probably wouldn't put ACE inhibitors. It's like their bronchial asthma. So they look at the client themselves.
What's good, that it's good, the ejection fraction is?
No, if the patient with a low ejection fraction like less than or equal to 40%, the normal 60%. No, if the patient, they'll put on an ACE inhibitor if they had an ST elevation MI, STEMI, with an ejection fraction. Because remember, I don't know if we have to talk to that, this is one of the slides. We get an echocardiogram done after 325, they really do, but not everybody. Yeah, it depends on the client. So we get the 325 with the MI, right? I mean, that's all. We don't have that, we have a pop, several, 81 milligram, you know, these 80, yeah. Any questions, guys? This tells me you're thinking really good, because that's what all the boards are about, you know, thinking about all this stuff, so. The question about it's pretty simple, but they're not as simple as you think, you know what I mean? Yeah. Nutrition therapy, you need to have an MI for at least 4 to 8 hours, you might have an NPO. There's still a little bit of IV fluids, just a little bit, you don't want to throw the heart failure. But, they expend too much energy eating, it takes too much oxygen, too much stress on the heart and feet. As they progress, we give the sips of water, we actually help them like that, they don't even start to they get very dependent on you after an MI, so be careful of that. But we want to take it slow, so the heart can recuperate. We eventually progress to a low salt, low saturated fat, low cholesterol diet. Procedure like a cabbage when it failed the medical management. Or if they have a left main coronary artery or 3 vessel disease involved in the bypass. If they're not a candidate for PCI, they can't get the stent in, the lesion's too long, too difficult, because that vessel is too narrow. Or you take it to the cath lab, we got the stent put in, but now they've reached stenosis, and we know they've reached stenosis or have angina. They should not have any more chest pain once that stent goes in, but they are. So then we can change the surgery. The main surgery is the cabbage, coronary artery bypass graft. This is where they're putting on a heart-lung machine. There's a perfusionist, this trained, a perfusionist, and actually your life is in his hands. His anesthesia during the surgery. On the heart-lung machine, it diverts the patient's blood from the heart to the machine. It gets oxygenated and is returned by this pump, this machine, to the patient. So we have perfusion in all the organs. Now remember, these surgeries take 4 to 6 hours, at least usually 4. So patients are on the machine for a while. There are complications. A lot of them end up with memory loss. They have amnesia. They don't remember things very well. And this memory loss can last up to about a year for some patients. But they're not getting demented or nothing. But they really worry about that post-op. They don't remember things. They can last up to about a year according to research. That's pretty much important to that. Now while they're on the heart-lung machine, they're going to be creating some bypass grafts, those occluded vessels, occluded arteries. They use the Staphylus vein from your legs. You can have a leg incision to monitor post-op, they use the Staphylus vein. But they normally use the internal mammillary artery. Internal mammillary artery is one of the main ones they use. Now the next slide shows that. So there's not going to be any leg incision with the internal mammillary artery. That's right. But regardless of which artery or vein they use, they're still going to use aspirin post-procedure daily to keep that graft opened up. This graft will not stay open with this artery vein in place if you don't have aspirin. They're also using, in the research, and I had a family member also, a brother-in-law, they use this great
too, and my husband used to get to go to the doctor for a checkup and just make sure. And it was right in his records and he had cabbage. And he would put out his right knee that's used his left arm. That was
Ladies, is radio? Oh,
and went to the leg.
I hear more about that. I thought it did, yeah.
And he would put out his right arm so that they could check his pulse that way, and inevitably the nurse would go for his left machine. They go with his record, kind of chuckled to himself, was like, I'm dead in that arm. You know, then he pulled his sleeve up and then, oh, okay. Like, that's why you give me my right arm. Because you won't feel the pulse over here, you're not supposed to. A lot of times it can be because it's something like that. It's not like, hey, it's like,
I think a little bit more complex situation too, because it's so involved, you know, and being
to
to
see
see
that
that
not
about
scar all the way down his leg. It's a little, that's worse than chest.
you know, guys, like, listen to me after so many patients tell me, that this is no I mean, the pain is so severe. Because it only takes at least 6 months for that to turn. And I've not known one patient that's now, they had the minimally invasive direct coronary artery bypass, big cab. I did a little bit of information on that from one cardiologist, right? I couldn't get a lot. That's the alternative to the CABG. That's what it, that's an anterior cervical heart in a tiny little incision between the ribs. This for a single or double vessel bypass. And they actually suture in the internal mammary artery, they suture to one of the main arteries there in the back. They didn't really say, it's for those those patients who are too high risk to survive the CABG, which is why they do it. I have never been studied with that procedure though, but they're too high risk to survive this. So they do this, incisions treat the ribs and everything. So it should be less painful in that tiny incision. I'm thinking they must have robotic surgery here too. That's the thing. Robots. And then we also have on the CABG surgery where they have the most common is the left, the mammary artery. And here they kind of leave it attached to subclavian. It lives off the chest wall and actually suture to that coronary artery distal to the stenosis. They use that venous vein. They're in. So there's different ways how they do it after the body. That's pretty cool. So I really, this is the beating heart. This is the beating heart, so your heart is still beating while they're doing the bicuspid. These are for those critical patients for end-stage COPD. They're end-stage COPD, their heart is still beating during the procedure. So they're critical patients with very low ejection fraction. So when they say very low, I'm thinking 20 to 30% maybe for very low, because they're almost 60 for ejection fraction. I'm guessing 20 to 30. And those end-stage COPDers. This is beating heart. And I did some research on this last year. I think it's really cool. I didn't know too much about it. There are some surgeons that do quite a few of these in other in big hospitals. The last I've ever taken care of a patient was a transarterial laser for vasculation. These are patients who have failed all the medical treatment and they have persistent angina, just that it never goes away. And this is done in the cath lab. This has a laser. What they do is they do the cath lab surgery by doing a left anterior thoracotomy. But they do it in the cath lab from what I've read. It opens up blood channels to get blood flow to those ischemic areas with coordination procedure. Those ischemic areas between the left ventricle and the lack of circulation is that. I've not heard of this much, I don't know too much about it, but that's basically all I just find out about that. And your book just basically said that too, but it wasn't too much out on that one. she wanted anybody else going there, she wanted us to just build up the family for her respiratory therapist to do it first. So we admitted first those of us who are licensed, have a little bit of knowledge, and they are just gross. They're not, they don't have to stay inside on that. Almost bad. So, you know, everybody in our family has some alcohol, and they do so well, so, see, I don't care if people say whatever you do again. I think the older people have more of the problem with, I really do, the pain. The pain is so severe. With that, the pain we got to just, that probably is the only thing that we can. Okay. Nursing assessment. We want to find out what the events are related to the current episode of angina. So we're back to chronic stable angina, ACS. So what are the events related to the current episode? We want to find out now what specifically are the meds that are taken, and are they taken as prescribed? We need to know, find out if they have a history of CAD, hypertension, diabetes, and heart failure. We're going to look at functional health patterns. First of all, do they have a sedentary lifestyle? You know, do they exercise, or they just kind of a couch potato, or have a desk job? What are their symptoms with exercise when they do walk a couple miles, or when they do exercise? Do they have dyspnea, fatigue? How do they cope with that? Is that when they have an angina? We do quite a bit of interviews here. We also want to know if there's a family history of CAD. Every family has a history of CAD to some extent. And then you'll do your objective assessment. If your skin is cool and clammy, if they're anxious and restless, with their chest pain, they're probably having an MI. Tachycardia, do they have any dysrhythmia on the heart monitor? Do you hear a murmur? Have they ever had a murmur before? Now they have one, so we need to find that out. What are their lipid levels? What's their white blood cell count? Because you know, increased inflammation, leukocytosis, heart damage. And what are the EKG results? If you're doing an EKG in the office, in the clinic, do we have T segment changes, depression, or elevation? We'll do a chest x-ray. Is there any pulmonary congestion on that chest x-ray? And we'll probably order an echocardiogram. We haven't had one for 3 to 6 months. We'll probably order another one. The insurance doesn't like to pay that, but if they're having symptoms that are worsening, it's not, you know, it's going to ACS or it's unstable, we need to find that out. And a lot of times in the hospital, they have to look back and order it, and no echo in the past 6 months, get it done today. Or, you know, so we have to look back. If it's done in Des Moines or Iowa City or wherever, or another town, a town, whatever, we have to get those results on the chart of the physician. Just order that result. Also, getting back to this here on nursing assessment, we focus on health perception and health management. We're going to discuss the risk factors like CAD and all this stuff with our patients, smoking. But we're going to ask them specifically for health perception, health management. Specifically, we're going to ask them questions like, how often do you get your cholesterol checked? If they're a new client to you, how often do you get your cholesterol checked? That means they are aware of keeping that cholesterol less than 200 overall to prevent an MI. We're going to ask those kind of questions for health perception, health management. ACOS has a lot of questions on them. Your textbook's really good on explaining that stuff. Try to read that for our next test too. Make sure you get health perception, health management, all that stuff in the textbook is important on this next test. These are all in-text questions. cardiac output. Overall goals, our plan is to reduce the pain, because what is pain? Ischemia, exactly. We want to preserve the myocardium, so that's why we have a 90-minute window. The time to hit ED to a cath lab. Time is muscle. Time is muscle. The more time we take, the more muscle loss we'll have. So, we want to limit that loss of muscle. Immediate and appropriate treatment. First thing we're going to do is put them on a monitor. Make sure they have oxygen on, get that EKG done, get your IV started, and get your meds going as ordered. We want effective coping with illness-associated anxiety. If we help them, keep them informed what we're doing to help them, that should help lessen their anxiety to a certain extent. Because anxiety causes more stress in the heart. And so it increases the workload of the heart. And also keeping them informed, helping them understand why we're doing this, prevent heart damage. It's going to actually help prevent complications overall. What the thought is here. We're going to talk to them about participation in a rehab plan, cardiac rehab plan. And we're going to talk about reduction of risk factors in regards to medications that are ordered, beta blockers, ACE inhibitors, nitrate, anti-cholesterol medicine, anticoagulants ordered. Their diet, low salt, low fat, low cholesterol. Their activity level. And then you maintain some sense of an activity level we talked about to reduce the risk factors in the future. Again, if you stay stable, we're going to do 30 minutes of exercise 5 days a week. I have an answer with that, then they need to see. Health promotion. We're going to talk about those therapeutic lifestyle changes to reduce cardiac risk factors we just talked about. The diet, the exercise, the medication. We're also going to educate at their level. And they never finished high school. Maybe they only can read at a 5th grade level, with such education in that format, or a 9th grade level. And we're going to talk about, we're going to answer their questions. We're not going to focus on all the causes and states, go in a real long captive discussion with them. That may increase their anxiety, and they're not going to hear what you say. Answer their questions, be supportive, and make sure they understand the importance. They can teach back to you why they're going to take these meds, why they're taking this specific med, why they're taking that specific med, what that med's going to do for them. When they know to call the doctor, they're going to be telling you all this stuff back. We're going to stop here for today, guys. I'll put this conversation.
Monitor your contract. I'll agree. That's what I was saying. That's the one I see. You had one on clinical last year too. My brain goes too.
this yesterday, somebody didn't get to. With chronic stable angina, chronic syndrome, the nursing assessment. One thing we want to really ask them about is health perception, health management questions. We're going to discuss the risk factors with them and ask them specific questions like, for example, how often do you check your cholesterol? How often do you have your cholesterol level checked? Those are things we need to find out from the client with CAD and that, what their knowledge is for a healthier lifestyle. Subjective data also includes events related to the specific episode of angina, what specific medications they're on, what's their health history, CAD, hypertension, are they history of diabetes or heart failure. Functional health patterns also include a family history of CAD, would be something we want to know. They have a sedentary lifestyle. They just sit all day, not really having to exercise. When they do exercise, what are their symptoms? Are they dyspneic? Can they climb a couple flights of stairs without being short of breath? Do they have fatigue or chest pain with any activity? Specifically, which activity that is? Bicycling, swimming, just walking long distances. And what are their coping mechanisms also are important to know too, because stress affects our heart overall too. Objective data, we'll do our own physical assessment when they present. Is their skin cool and clammy? Are they anxious, restless? Is there tachycardia? We'll look at the heart monitor rhythm. Do they have any dysrhythmias? Have they ever had a heart murmur? We'll want to know that from the chart. And with our own physical assessment, if they have a new heart murmur, that could point to a problem of worsening also. What are their lipid levels? We'll look at a CBC, because anemia also affects the heart. Leukocytosis tells us about the degree of inflammation with these episodes of chest pain as they progress. We'll look at EKG. We're always on the hunt for ST segment changes, elevations, or depressions. We'll do there's always be a chest x-ray order to look for pulmonary congestion. And a lot of times there's a baseline echo done also to look at the function and motion of the heart valves, the chambers of the heart, the blood flow, ejection fraction, all those things that we need to have a baseline on. There's the diagnoses, and all of these apply. But probably one of the most important ones up there is the acute pain, because pain is ischemia. So we have an imbalance of oxygen supply and demand. And of course, we're going to see some ineffective tissue perfusion with empty blockage, either partial or complete. Anxiety can be related to perceived or actual threats of death. Sometimes these patients have a sense of doom when they're having real bad episodes of chest pain, discomfort. And activity intolerance. That can be related to fatigue because of a decreased cardiac output. Overall goals. Goal number 1 has to be relief of pain. Pain is ischemia. We want to preserve as much heart muscle tissue as we can for preservation of myocardium. Remember, time is muscle. You have that window of time to hit the ED to the cath lab, no more than 90 minutes. Time is muscle. The longer it takes to get them there, the more muscle damage we're going to have. Immediate and appropriate treatment. Again, put them on telemetry, oxygen, nitro, morphine, we're going to use Mona, we're going to go through all our protocols, and do them in a timely manner. Get those labs drawn, the troponins and everything. And again, we're going to look at effective coping with illness-associated anxiety, because we know the more anxious the patient is,
medications they need to be taken as ordered. Getting their lipids checked at least once a year. So all those things are important. No. Morphine's always after the nitro. The morphine should take the pain away, nitro doesn't. That's always been a misconception. That's a good question. I have a sore scratching throat, guys, so be sure and holler. I don't see you too. When they first come in, we put them on telemetry, put the oxygen on them, and then we give the nitro if they're having ongoing chest pain. Sometimes you get them down to ER on the floor, the pain's gone, right? Briefly, and then it comes back. Yeah. This is the oxygen to them, yeah. Usually telemetry, oxygen, then nitro, and then, we also do morphine. Yeah. We have protocols for everything. We just do it automatically, I'm sorry. We give plavix to the ER a lot. We have all the protocols. Just, usually the physicians are with you. We just tell you everything you need. You had a question over there? We want no pain, right? Because pain's immediate, yeah. No, you can give them morphine if they don't need it, you know what I mean? If the nitro takes care of the job, but a lot of times it doesn't. They might still have the pain that is one, so you still give them morphine. A lot of times the docs down the ER, those might be given anyway. It does help because it's still it helps with that perfusion. Health promotion. Therapeutic lifestyle changes, reduce the cardiac risk factors we talked about. So watching their diet, exercise, taking their medications, getting their labs checked, stop smoking. There's a lot of health promotion on NCLEX with CAD in that. But we're going to teach the patient their level of education. We're not going to talk to them about all the causes of CAD, go into a real long explanation of how the heart works. We're not going to do any of that. We're going to answer your questions as simple as possible based on their education level. Find out they have a support system too, because they need to have a support system. So you're actually listening to both the patient and family's concerns to make sure they understand. They need to teach back to us everything we're teaching them so that we know they have a good understanding. So, for example, I'm going to take this metoprolol here because it's going to slow down my heart rate a bit, it's going to help my blood pressure, and it's good for my heart. You know what I mean? The doctor says if I take it, I'm less likely to have, more complications with my heart. So they need to explain their medications to you on why they take them. Yes, I'm going to take nitroglycerin. I'm going to keep those little pills in that little brown bottle. They should have a little stinging under the tongue when I take them, so I know they're good. You know what I mean? So I take that when I first get the pain. So you need to teach you back. And at home, remember at home, the protocols change. If they're home alone or with their family and they're having chest pain, they pop a nitro or spray under their tongue there. After the first dose, if the pain is worsening or unchanged, they call 911 and then take the second dose, 5 minutes later. So we need to make sure they understand the protocols changed at home too. We're also going to teach our families, they need to learn CPR, right? CPR is so important. We do a lot of that teaching, signing up for classes and everything. Yes.
For the last year, we learned that there's no resource, but they take the first pill, they lie down, and then 5 minutes later it has to stop. They take the second pill, and before the third pill, they call.
I know, that's changed since then. That has changed since then, I know.
It is changed.
Yeah.
Last word.
It's changed, no. Cardiology's changed it too. After that first pill, early entry in the healthcare system is most important. We have too many people dying at home.
Oh, okay.
Yeah, and that's why your textbook even stressed that too. And I was surprised. First time I ever saw it in print. I just know it from the cardiologist. But yeah, that first pill, in 5 minutes, they're not doing better. If it's getting worse or it's about the same, they need to call 911. So nitro should work within 2 minutes, 2 or 3 minutes. It should take that pain away. So yeah, but that has changed. You're right, because when I taught NA1 last year, we were still at those 2. Now we're down to 1. And that's important to remember. And changes, elevation of depression. We're hoping to see prompt pain relief first with the nitrate. And then we'll follow, if the nitroglycerin is not working, we will give morphine. And also vasodilating. And that should take away the pain if nitrates don't. We're going to listen to those heart sounds. We're going to make sure the patient's comfortable in their positioning. And yes, they need to lay down after they take that nitro. I had one guy years ago on the surgical floor. He's having some chest pain, rubbed his chest, walked on my chest, and certainly and so I gave him this nitro. He would not sit or lay down. And I said, you know what, sir, you're making me nervous. You're getting dizzy here. He's like, we gave nitro. Oh, honey, I'm used to this all the time. I pop at home, no big deal. Finally, after the third one, two of us nurses drug him down. You know, he just would not lay still. And I think it's just anxiety and fear. He just, he was a nursing complication. Oh my gosh. They don't understand. You don't understand that they need to lay down because it's going to drop their blood pressure and make it like a dizzy. And he had a headache too, of course. We gave Tylenol. That's a side effect too of nitrate. So it's a violation of it. We're going to monitor vital signs for these clients always. And I always take vital signs with each nitro I give. Within 5 minutes I'm checking the blood pressure and that again. And we always stay with the patient. We usually don't leave them alone when they're having chest pain. We want to encourage them. If the chest pain goes away and comes back, we want them to put their call light on as soon as possible so we can make these interventions. There's nothing more upsetting to a nurse when you go into that room and they go, oh, hi, I knew you were going to come to make rounds here shortly. My chest has been hurt for like 15 minutes. I mean, that's the last thing you want to really hear from these patients. 15 minutes is not good. And it may not be, if you go look at telemetry, because you're moving around, you're not at the central tele, you may not even know any changes unless the teletech tells you there were some changes since you pages yet. Patient teaching again for home care about coronary artery disease, angina, what's the precipitating factors for that, how we can reduce those risk factors, what medications that need to be taken, again, how to take that nitro we talked about, the beta blockers, the calcium channel blockers, what's the side effects of these medications, and when to call the doctor. And the family, again, needs to know, someone needs to know CPR. We want to make sure they get signed up for our class. Years ago, we used to teach, especially the parents with the babies with heart problems. We used to teach the parents in the hospital CPR babies when they left the hospital. Anymore, we have to sign up for a class. Acute interventions. We have Ramona. They're on continuous telemetry monitoring. And remember, our first contact with that client is with angina is to put them on that heart monitor. We need to monitor them. We're going to get EKG because that's our first evidence of any changes in their heart rhythm, especially at ST segment. We'll get vital signs, pulse oximetry. We'll listen to their heart and lungs. We'll get those labs drawn that are ordered. We're going to make sure that with these patients, especially those who've had an MI, that they have to balance rest and activity. Usually the first 12 to 24 hours, they're on bed rest after an MI. And they will begin a cardiac rehab program here within a few days. Day 2 of the hospital, we start talking about cardiac rehab briefly. Because a lot of times these patients are still in shock or denial, they've had a heart attack. When they're in a state of denial, which is on this next PowerPoint here, we really can't talk to them if they're not ready to listen. They have high anxiety, and this denial that they're having is a coping mechanism. Because sometimes they don't even realize they've had a heart attack, and that's what's bad when I floated. So I always ask the report, does the patient know they had a bump in their troponin, that they had a small MI? Well, whether they know or not. We're not sure if the doctor told them yet. So how would you take care of a patient like that? You know what I mean? It's nice to know what they know from that standpoint when you're taking care of them. So a lot of times I'll ask them, so what did the doctor tell you about your heart? You know what I mean? Well, he's not been in yet today, you know, but I think I must have had a small heart attack. So I've had one before and felt the same. You know what I mean? But you have to know. Some people have large, you know, quite a bit of damage in that too. So it's always nice to know. But again, denial is a coping mechanism. So they're going to have this emotional behavioral reaction. We're going to maximize the family support system here with them. We're going to let them spend more time with their family at the bedside. Some of them get very depressed. They worry about dying. Once the doctor said you had a little heart attack, even, that means that they're going to die. So they don't quite understand that, you know, your heart's recuperating now, but you did have some heart damage. When we talk about cardiac rehab on day 2, we just tell them the cardiac rehab will be starting within the next few days. Someone will be in to talk to you for cardiac rehab. Cardiac rehab should be a 12-week program. Is anybody familiar with cardiac rehab? Have you been there on the clinicals yet? Awesome, that's not, yeah. It's usually on an outpatient basis, usually 1 hour 3 times a week. Again, it's going to be based on their ability to do what's expected in cardiac rehab. They have step 1, 2, 3. There's different steps on that too. We just bring that to their attention. There's cardiac rehab. There should be in talk to them. So when they go home. Now, cardiac revascularization. I think this is a little confusing slide. They're talking about a CABG surgery here. Okay, this is CABG. Coronary artery bypass graft. So, if the visit to the catheterization lab was not successful and they could put a stent in to open up a blocked artery or arteries, they usually end up going to surgery for a CABG. And on this slide here, remember, CABG is not a cure. It's just it's an intervention to keep that blood flow circulating in your heart. They're in the ICU for the first 24 to 36 hours. They have all those lines in that Jana's been talking about. They have a pulmonary artery catheter for measuring cardiac output on the particular function. They have all the other hemodynamic monitoring that she's been talking about. We have the ART line put in for continuous blood pressure monitoring. They'll have a chest tube in, 1 or 2, depending on, usually there's 1. And that's to help keep that. There's a lot of blood that pools around the heart during the CABG procedure. So that chest tube's in there for drainage. It's usually in there for about 2 days. We'll be monitoring the drainage in that tube too. We'll have a continuous EKG monitor to detect arrhythmias. Normally when you're in a cardiac surgery, the heart gets very irritated with all this manipulation of the heart muscle. So a lot of patients have atrial fibrillation after the procedure. And some have some ventricular arrhythmias too. But the biggest thing is that they found was that even if they give an antiarrhythmic like amiodarone during a procedure, the patient still has a tendency to have some episode of atrial fib briefly after the procedure. And it's because of the manipulation of that heart tissue. It's pretty common. They're on anticoags during the CABG procedure if you're familiar with it at all. And I know we don't talk too much about it in this class, which I wish we could, but they have heparin to prevent clots during procedures performing. Heparin also tends to cause a lot of coagulation problems. It tends to cause more bleeding going on when you're on that heart-lung bypass machine, the standard procedure for CABG. So we have to monitor for bleeding and everything after the procedures. These patients need NGN to keep the stomach compressed. And of course, if an endotracheal tube in the ICU and on the ventilator. And the arterial catheter line is usually more breakable than radial. You might never seen a brachial art line myself before, but I kept seeing what the cabbages they do. Okay, the art line can be radial or brachial, but a lot of times they use that radial artery if they have like a triple bypass or something. So they might put the art line in the brachial. That's what I'm talking to Jana about too. We're so used to seeing the radial, you know what I mean? And that's what, I think your textbook mentioned brachial on that too. Yeah, they have to have an art line in what you have, you're right. Only artery you have. With it can be. Because a lot of times it can be. Because some, you know why? We usually see the radial artery, but a lot of people use one of the radial arteries for one of the grafts, like a triple or quadruple bypass. So again, that's why they put the radial instead. So. Now, the infiltrate tube, of course, are hooked up to mechanical vent. We usually extubate them within 6 to 12 hours. Usually it's closer to 12 hours. What they usually do is they're on all these drips. They're on a nitro drip. They're on, oh gosh, they're on a bunch of stuff here. Propanol drip to keep them sedated. They wean them off those drips as the patient wakes up. We don't want to wake the patient up abruptly because that stresses the heart. So we allow the patient to wake up on their own. Once they're woken up, that's when we usually extubate them, as long as that hemodynamic volume is stable. We have to make sure that all that hemodynamic volume, all those lines Janet's been talking about, all that cardiac output, everything there is pretty well stable before we take them off that vent. But most patients get off right away. There's too many complications the longer we leave them on. Also, they can have epicardial pacing wires for emergency pacing of the heart. They usually put them in atrium and ventricles. They insert those during the procedure, and they just kind of pull those wires out if they don't need them after the procedure. Again, they're in there for about 12 hours. And that's in case they have to have an emergency pacing put in. We have a urinary catheter to monitor urine output, which sounds feasible because we're monitoring all outputs very closely because we worry about compromise to our kidneys after having a bypass surgery too. And then we have the NG tube in for gastric compression. And that comes out too within about 24 hours also. The patient should be able to take sips of water and everything else after that CABG procedure. They do pretty good, really the ones I've seen. Complications related to cardiopulmonary bypass. So with the CABG. Now the heart lung machine. Bleeding underneath. First of all, they have systemic inflammation from the process itself. So we talked about how that worked yesterday with that machine, briefly. They have bleeding and anemia from damage to red blood cells and platelets. Remember, these procedures last 3 to 5 hours. And there's heparin used. And we have a lot of things going on with that because a lot of times they have to reverse the bleeding to a certain extent by giving them protamine, you know, the antidote for heparin after procedure. Some patients tend to bleed more, and the problem here is they've been on Plavix. They do say that a cardiologist's dream drug is Plavix, but a cardiovascular surgeon, Plavix is a nightmare. Plavix tends to make them bleed more. They like the patient off Plavix. If this is a planned surgery, which is not always planned, are they? They're more emergent. They're right from the cath lab to surgery within 24 hours sometimes. They wouldn't want that Plavix about a week. They tend to bleed too much. And in addition to that, they're on with the procedure, so. Because the bypass machine does include, it's heparinized. So a lot of times protamine sulfate is given after procedure, just in small amounts to help control the bleeding. Very rarely do they take a patient back to surgery because of the bleeding, but it can happen. Again, if they haven't been off that Plavix about a week, pre-op, we have a problem. There's about at least 300,000 CABGs performed in the blood flow and the heart going. Fluid electrolyte imbalance. As you can imagine, they're getting a lot of fluid during this exchange. And they're on Lasix strips, on small amounts of Lasix strips coming back from the procedure to help control, again, cardiac output, cardiac index, pulmonary pressures. All this hemodynamic monitoring is ongoing on these clients that Jan's been talking about. And they are so strict on the fluid anymore. These patients tend to go into fluid overload so easy. Most cardiologists won't let them have more than 75 milliliters to 125 milliliters an hour tops for 12 hours post-op. They have to have a little bit of fluid, but not too much. They tend to go into fluid overload too quickly. And then you have them on a Lasix strip or a Vumix strip. They can also get fresh frozen plasma for the bleeding if they have to. They have done that in the past. Depends on the client again, because there is a small amount of oozing. You'll see that in the chest tube. You'll see that from the incision sites, from the graft sites. Hypothermia. Okay, they're on that machine for 3 to 5 hours. Hypothermia, again, there's so much past biz on that again. Hypothermia, decreases our metabolic demand. And we have an open body cavity for 3 to 5 hours, you guys. Because remember, they're cutting through the sternum and the ribs and open up the chest completely to get to the heart. And just in a routine cavity procedure. Normally, the temperature of the patient is less than 36 degrees centigrade by the time they hit recovery room and then ICU. So the heart-lung machine has the capability of starting to rewarm the patient to a certain extent. We don't want them shivering, because shivering is going to increase their metabolic needs. We require more oxygen in that too. So, but that's our body's compensatory mechanism to control that. But the problem is that shivering can also lead to lactic acidosis. So we manage that with sedation and neuromuscular blocking agents while they're on the vents. So try to control any shivering, because that's a complication there too. And again, the machine, the heart-lung machine, does start warming that with some fluids in that. And in the recovery room again, they use some warming blankets and that too to help prevent shivering. So that's a big thing there too.
Shivering.
Lactic acidosis, he said, yeah. Lactic acidosis, metabolic acidosis, yeah. So, I didn't know that either. I never thought about that before. I didn't appreciate it. It's actually a chemical.
Are they
They can, yeah. Yeah, not always. Well, I shouldn't say that. It can be as early as recovery room, and the gentleman on and then a lot of times in the ICU. A lot of times the cardiologist kind of will write those orders too. I was told that. I think it's really exciting. I'm sure you have this family. Yeah, I've had several family members, as I told you, young ones with cabbages, and one was obese, and one was real bad by fatty. So that's the problem with CAD and African. So they were double bypass and all these stresses. Okay. So the nursing care is focused on assessment for bleeding from the chest tube drainage, from the incision site. We're going to be monitoring fluid status very carefully. Again, we don't want to overhydrate these patients. We're going to be running a bunch of lab work, checking electrolytes, replacing those that are needed in the IV solutions. Again, these IV solution rates are pretty low, pretty slow. They're mostly drips. Those drips like the nitro drip, the Lasix drip, all those come off slowly as the patient comes off the vent too, a lot of times. If, again, they're hemodynamically stable. And they look at all those pulmonary pressures really closely, the urine output, again, And we're going to restore that temperature with warming blankets. What we do know after these procedures also is if a patient has a history of heart failure, if they have a weak heart pump, they're 6 to 9 times more likely to have a ventricular dysrhythmia post-procedure. So if they have a history of heart failure, 6 to 9 times more likely to have a ventricular dysrhythmia or sudden death after these procedures. Now these procedures, when you're on that machine 3 to 5 hours, that's a long time that they're working on you. And there is a rare chance of throwing a clot and having a heart attack or stroke. It doesn't happen very often, but there's always a chance. We're going to do DVT prevention on these patients too. Again, we're monitoring their bleeding, but we still want to make sure that we can reposition them a bit in bed and that to keep the blood flow going. Their pain is intense. They need opioids. So we're going to give them Dilaudid or once they're awake and alternate, we're going to give them Dilaudid and other medications to make sure that their pain is met. They say it takes about, and it kind of varies on the client, they say it takes at least maybe 9 weeks to 3 months for that to turn the heal. Some cardiologists say it takes actually 6 months for that to really feel more comfortable. So, and that really slows down the rehab process on these clients is that sternal pain. It's really bad. We're using a spirometer. We're going to teach them how to use that and assist them with it. Cough and deep breathe. When we talked yesterday in the brief about post-op cognitive problems, remember? Being on that heart-lung bypass machine that long. 40% of patients for several months after the procedure still have some amnesia and some memory loss. Sometimes some patients last up to a year, especially the older patients. So you want to tell them they're not losing their mind. This is an expected outcome. Hopefully it will improve within a year, and it will with some it may not. But that's something that really worries them. And then we're going to care about that limb graft, remember? So if they're using that saphenous vein, we're going to look at that site on that leg and do any cares for that. Watch an incision, might be losing some blood in that too. So we're going to be looking at all of those incisional sites very carefully, those graft sites. Okay, home care, patient teaching again about how to limit the factors of CAD. Physical exercise. When they go home, because remember, it's not a cure, these revascularization procedures. So CAD does not go away. They still have it. But we want them to teach them for physical exercise, if their heart rate increases greater than 20 beats per minute, they need to rest. So if the heart rate increases greater than 20 beats per minute, when they are exercising, they need to stop and rest. And I want you to remember that, greater than 20 beats, they have to stop and rest. Some are worried about sexual activity, especially the younger ones. Again, it does come up. Emotional readiness of the patient and the partner themselves. What we tell them is this in regard to physical expenditure. We want them to gradually resume any activities that they're used to doing, gradually. But when energy expenditure, when you're having intercourse, it's equal to climbing 2 flights of stairs, they say. So when they feel they're able to climb 2 flights of stairs with no difficulty, they can go ahead. And that's kind of how they talk to it about. That's how the cardiologist actually talks to the patients. We're going to teach our clients how to check their heart rate. Again, they need to know if it's greater than 20 beats a minute when they're exercising, they need to stop and rest. We're going to talk to them about completing their medications as ordered. These patients have to be on an aspirin a day because of those grafts. Those grafts will not stay open. Those bypass grafts, if they're not on an aspirin a day. 81 or 325. 81 or 325. Again, it's up to the surgeon. It's up to the surgeon on that. rehab process. We're going to look at perception of the myocardium. So we're going to look at the heart rhythm. If there's any EKG changes. We're also going to get an echocardiogram done to see how they're doing. We talk about immediate and appropriate treatment, effective coping with the illness. Again, they have a lot of anxiety. Some of the elderly have depression, and we need to check the signs of depression in our clients. Because they will tell you, don't you ever send me to a capture procedure again. It hurts too bad. I would rather die than go through this again. The pain, you can't imagine the pain. You're too young to understand. Even the young people do that too. The pain is too many. No way. Never again. It'll be the beating heart one they can, or another procedure, a mini one, but not this one. Participation in rehab plan again is part of the expectations for getting well and learning how to build up the physical strength. Reduction of risk factors again, no smoking. If you're obese, you need to lose weight, and we need to help with the diet on that. Then you need to exercise. We talk about walking, swimming, bicycling, jogging. Again, we want to rebuild that endurance in these cardiac patients. Now, this next topic I'm going to talk about is sudden cardiac death. And if anybody can definitely when we're talking about this, it's okay. Last term I talked about aneurysms. I tend to enjoy talking about aneurysms, you know, and I didn't realize there was something in the class that I had lost a friend pediatric surgery aneurysms. So if there's anybody in here, please definitely leave when we talk about sudden cardiac death. I understand. Okay, this happened in my family, and sometimes it could be very cheerful subjects to talk about. Sudden cardiac death. Now, this is not a heart attack. There's no blockage. We have 325,000 people that die a year from unexpected death. 80% is CAD clients normally. The risks are smoking, a family history of cardiovascular disease, a high cholesterol level, and an enlarged heart. What we're talking about here is an abrupt disruption in cardiac function. We have electrical malfunction in our heart that occurs. It's so irregular, the heart speeds up so fast, and then it just stops. It loses cardiac output and everything. Death usually occurs within 1 hour of the presenting symptoms. A lot of times the patients that survive will say, all of a sudden my heart started racing. It just started racing, I got dizzy, and that's all I remember. Sometimes people have no symptoms at all. I took care of one guy. He came to the hospital. I can't remember what he was in for. He said, well, 7 times this doctor saved my life, he told me. I'm thinking, oh no, you know what I mean? So I can't remember what he's there for, but I was thinking, oh my gosh, I hope he doesn't code on me while he's here. But he had been 7 times they brought him back. What are the odds, you guys? People usually are not that lucky. This tends to happen again. This happens once, but usually, more than twice. That's why there's a lot of testing done to try to prevent this. So we know that most of them are caused by ventricular dysrhythmia, specifically the VTAC. And less common, it might be a left ventricle outflow obstruction, like stenosis or something. But the immediate treatment, has to be CPR and defibrillation. Primary risk factors is ventricular dysfunction, left ventricle. The ejection fraction. The ejection fraction, I'll define that in case someone will have a question. That's the amount of blood pumped pumped up by your ventricles with each heartbeat. Normal is 55 to 65, so I always say 50% is measured in percent. And we find this out a lot of times. It's easiest to find this out on an echocardiogram. We always do echoes on these patients always, just like because we want to find out what happened here with that. But these clients here normally have ejection fraction less than 30 to 40% actually, but Cleveland Heart Clinic, Mayo Clinic, a lot of places say 30 to 40% their ejection fraction. It's not up there around 60, you know. And another thing they found, the ventricular ischaemic involvement MI. Most of these patients had a previous MI within 6 months. That is, 75% of the patients found had an MI within 6 months of this episode, a previous MI. It's a percent of blood pumped out at the ventricle of each beat. Yeah, but it's a yeah, that's how the cardiologist says, yeah.
How strong is it? If it's strong, it's going to go finish.
No, normal is around 60%. They said 55 to 65. We usually go normal ejection fraction. Normal ejection fraction is around no higher than 65%. Had a previous MI within 6 months of this, yeah, happening now. You know, they probably didn't even know they had one, you know what I mean? So that's what's sad, yeah.
So is it true to say that when it starts getting feedback and it's going faster, that it's not good any blood?
No,
And that's
yeah.
something
The
wrong.
V-tach goes right into V-fib, so it just starts quivering and you lose all your cardiac output, yeah. And you're dead, yeah. Also on here, we're talking about V-tach after an MI. Those who had prior episodes of sudden cardiac death, those who had a family history of sudden cardiac death, this tends to run in some families. Anybody who's had a history of an abnormal heart rhythm that's extremely slow, or anybody with a real long QT syndrome, which involves ventricular equalization problems, and then Wolff-Parkinson-White syndrome. Have you heard of that one before? WPW. Okay. Those people have a real wacky conduction system. I'm going to talk about it in one other slide. But they have like a supraventricular tachycardia problem, and they have different pathways of entry that kind of spout off. They have like shortcuts in their ventricles that their rhythm takes. A lot of times it's a gentle disorder, but not always. And that would be another risk factor for those. Okay, now, this happens more frequently in men in their mid-30s to mid-40s. Men have twice as high risk of having sudden cardiac death in a woman. They say, especially Afro-American, I did not find that in the research about Afro-American as being the primary. I didn't see that. I didn't look this up last night. I really didn't see that. Male gender has been basically what they focused on. Family history of premature atherosclerosis, smoking, diabetes, obesity, recreational drugs, hypercholesteremia, hypertension, and cardiomyopathy. Dilated cardiomyopathy is 10% of the cases. And then again, mental heart defects like Wolff-Parkinson-White syndrome. So there's a lot of, and proarrhythmic drugs can also cause them. There's so many risk factors there. I mean, there's quite a few. Diagnostic workup, we need to rule out or confirm cardiac markers, the serial markers, every 6 to 8 hours. We're going to use serial EKGs, again, ongoing, every few hours, just to see if any changes in their heart rhythm. We'll more than likely do it to the cardiac cath lab too, because they probably have some CAD. So we can check out the location and extent of any coronary occlusion. And then also, if there is indeed a problem, we need to fix it. So it would be a PCI or a CABG. A 24-hour home monitoring is effective. If there's no evidence of an acute MI, and this actually Holter monitor helps us with what your heart rate rhythms doing in your normal day-to-day activities. So it might pick up on something out of the ordinary there. They can also do exercise stress tests to see how patient heart tolerates the stress. A single average EKG. Have you heard of that before? It's a real detailed EKG. They do mobile tracing over a period of 20 minutes. So the patient has to lay down for 20 minutes. And the point is to capture any abnormal beats that might pop up. So it's a more detailed EKG. It spits out a report from the cardiologist. So you can actually look at this. An EPS. When a patient has an MI, scar tissue forms in that area. And scar tissue increases the risk of VTAC. So we have special doctors, electrophysical, and also cardiac surgeons who like to perform this test, and they can actually go in and do an ablation to disrupt those electrical pathways in the heart that are causing the problem. They can also go in and cut out that dead tissue too. So that's where the scars will be formed over that. So that would be the purpose of that. And then we have the ICD, and I think Janice talked about that, implantable cardiac defibrillator. That constantly monitors our heart rhythm. I call that our guardian angel, actually. It constantly monitors your heart rhythm, detects any fast, abnormal rhythms. It shocks that heart muscle to change it back to a sinus rhythm. It records every episode of this, and it prevents reoccurrences. I'm not sure how these reports are actually transmitted, you know what I mean? But the patient can usually tell. They can always tell when it's shocked. And also, we're going to put these patients on we're going to put them on an anti-arrhythmic like amiodarone to help decrease these episodes of problems. So, too, that would be another thing that the physician would probably consider for that, too. Psychological adaptation. The patient knows that they were dead and they were brought back. They fear it's going to happen again, and it more than likely will unless we do all this testing to find out the cause. They worry about how it's changed their life and how people perceive them. They're not going to be able to drive. They may have to change their occupation, depending on what it is. So we're going to teach the family that someone needs to know how to do CPR. And the patient, lifestyle changes have to be made. If they smoke, they need to quit smoking. If they're obese, they need to lose some weight. If they don't exercise, they need to start doing that. Once it's safe for them to crash through some exercise. They need to maintain a low-fat diet. And they also need to manage diabetes. If they're diabetic and it's not well controlled, it needs to be managed. So there's a lot of things to look at here to help prevent this again.
Circulation. So we'll have that KBD.
Hi, Jessica.
Hello, Clarice.
We've got KBD, we've got elevated right atrial pressure. Hepatomegaly, splenomegaly, ascites, peripheral edema. What we're gonna see in a lot of our patients, they're gonna have symptoms of both. Because they're gonna have both left and right heart failure. What we want to try to prevent in our patients with heart failure is what they now refer to as acute decompensated heart failure. Basically, this is fancy term for pulmonary edema. We want to, because once they have heart failure, they're going to always have heart failure. They want to keep their symptoms under control. But when they have acute decompensated heart failure, means their lungs are filling up with fluid. They can't breathe. So we see with acute decompensated heart failure, early symptoms, an increase in their respiratory rate, decrease in their PaO2. Those are early signs. Respiratory rate just starts creeping up a little bit. Instead of 18, now they're screaming at 23. Worry? It may be better if they got this atrial fib. And actually, it's the most common dysrhythmia we see. And with our patients with heart failure, that can make a big difference in their cardiac output. Losing that atrial contraction actually can drop their cardiac output 10 to 20%. Okay, they already have issues with having a cardiac output that's high enough to perfuse their system. Now we've just cut it back another 10 to 20%. They're going to get into trouble. It also increases your risk for stroke. So we're going to see, we're going to try to get them out of it. We may try cardioversion. We may try antidysrhythmics. We will put them on some anticoagulants to try to prevent clots. Exactly how we do that is going to depend on how long they've been in it. If they come in and we know, oh, this only happened a few hours ago, or within the last 24 hours, we could go ahead and try to cardiovert them right then and there. If we don't know how long they've been in it, then we're going to put them on anticoagulants and we're going to wait until we get the blood thin down before we try to cardiovert. Because the abnormal blood flow and the risk of clots, if they've been in it for several days and they happen to have a clot in that right atrium and we cardiovert them, they got and they can check it with an echo. But then you're looking at hundreds of dollars for an echo when we could just go ahead and put them on something and wait. But that an echo would be a good way to evaluate for it. We see our patient with heart failure has an increased risk of dysrhythmias, fatal dysrhythmias, going into VTAC, sudden cardiac death. Did you talk about sudden cardiac death? Heart failure can lead to severe hepatomegaly, so we could have liver failure, renal failure. Now this term, renal insufficiency, you'll probably hear that from time to time. That's the early stages of renal failure. So if you hear the term renal insufficiency, it means their kidneys aren't working the way they should be. They're not bad enough yet to be considered renal failure, but they're not working the way they should. And if we push too far one way or the other, we could push them right into it. Diagnostics. Well, we want to try to determine the underlying cause, because if we because this can help us determine, is this breathing problem coming because of heart failure, or is it because of respiratory problems? If their BNP is elevated, they have heart failure. Let's load them up with the Lasix. If it's not elevated, it's respiratory in nature. We better load them up with Solumadrol and see about if they need the ventilator. Diuretics aren't going to help because their shortness of breath is not related to that fluid overload. Because sometimes you can't tell. Maybe that person comes in, they're so extremely short of breath, you really can't hear anything moving in their lungs. And they do have a history of both COPD and heart failure. So we don't know for sure what's going on, so we're going to give them oxygen and maybe we'll go ahead and give them enough direct treatment, we'll get labs drawn. And then it's going to come back up. Even though we can't hear anything moving in their lungs, that BNP is elevated, so they probably got fluid in there, and they got so much fluid we actually can't hear anything moving. So we'll give them some Lasix. Use that to help differentiate. Yes? Oh, I think it's less than 100. So you don't need to know the actual range. Remember what we want to use it for. What it tells us. But I want to say it's less than 100. We may do hemodynamic parameters, an echocardiogram, stress testing, cardiac catheterization, get that ejection fraction. We actually have some different classification systems we can use to rank our patient. The New York Heart Association has classes 1 through 4. The American Heart Association, American College of Cardiology lists them in stages A through D. And these are just guidelines saying, okay, if you're in this classification, we're going to do these kind of treatment things to try to help prevent you from progressing on into another. And to try to prevent your condition from getting worse. And you don't need to know those classifications that, oh, I got this symptom, they're in this class, get this symptom, they're in this class. At this point, but our treatment goal, we want to try to decrease their symptoms. We want to improve their left ventricular function. We want to try to reverse or actually slow down that ventricular remodeling, which is when that tissue either hypertrophies or continues to stretch out. So we want to slow that down, try to maintain their cardiac function. We want to improve their quality of life and try to decrease their mortality and morbidity rates. The Joint Commission has actually outlined treatment plans and things that hospital facilities are supposed to be including in the care of patients with heart failure to try to decrease hospitalizations for this issue. yeah, and those kidneys were not working, then they would look at ultrafiltration or actually even just doing dialysis. Exactly, because they know their kidneys aren't gonna respond to those diuretics. Yeah, good question, yes. Now, another thing that we're gonna do, reduce preload. This one's pretty simple. Sit them up in high balance position, and we want their legs horizontal. That's going to decrease preload. Sit them up in high balance position with their legs horizontal. It's going to decrease preload because it's decreasing the venous return. Because, you know, if you're laying down, it's just going to go right up. If you're sitting up, okay, for that blood to get back up to your heart, body's got to work against gravity to get it pumped up there. It's still going to get there eventually, but it's going to take it a little bit longer. So but we want their legs horizontal. So we want them sitting up. We don't want them dangling their legs over the edge. Because we don't want to make any edema in their legs worse. So we want horizontal and sitting up. Which will probably feel better to them anyway because they can't breathe anyway. They won't want to lay flat. But sitting in high balance positions with their legs horizontal, it's going to decrease the preload because it's decreasing the venous return.
Having their legs horizontal, that's what it's already.
The fluid but it takes time for it to reabsorb. Normally that reabsorption takes several hours. So their lungs are already sounding funky because they can't breathe, because they're full of fluid. So this is one thing we can do until we can actually get rid of the excess. But we don't want even more fluid in those extremities.
It doesn't quickly slow down.
It slows it down, and actually it relieves some of the symptoms. So it's going to help decrease their feeling of shortness of breath. But if you actually look at the physiological response in the body, it's decreasing the preload just by doing that. So this is something we can do while we're waiting for the Lasix to kick in and work. Does that make more sense?
Got it.
I mean nitroglycerin. Even if they're not having chest pain, they may put them on IV nitroglycerin because it also decreases the preload. It also increases the blood flow to the coronary artery pressure greater than 90. Oh, morphine's a wonder drug, especially with heart failure. Because morphine helps to decrease afterload. And you'll see morphine's on my next slide too. Morphine. If you're allergic, not allergic. Because, in all my years of working in critical care, I never had somebody I couldn't give morphine. So I've never, so I'll have to do some checking and let you know what we use instead of morphine. But I want you to remember morphine. Morphine, it decreases preload, decreases afterload, decreases your oxygen demand. It reduces our patient's shortness of breath. It reduces anxiety. So if my patient comes in acute decompensated heart failure and the doctor orders me to give Lasix, morphine, started on IV nitroglycerin, and give an aspirin, first thing I'm going to give, morphine. This is heart failure. Not your MI. This is heart failure. So your patient comes in with heart failure, the first night I want to give them is morphine. It's going to reduce their anxiety, it's going to improve their breathing, it's going to help reduce some of their preload and their afterload. And then we'll get the other things in. You'll see probably why I'm giving the morphine in this side, somebody else is giving the Lasix over here, and somebody else is doing this, and somebody else is doing that. But if you're all by yourself, give the morphine first. It's going to buy you just a little bit of time until you can get that 80 milligrams of Lasix drawn up and give it. You'll have to wait till you have an order for it, but you would not wait for your ENP. And sometimes, depending on how busy the lab is, that might take an hour. We're not going to leave our patient in distress for an hour, waiting on lab work. Nasratide. The last one on this slide, Nasratide. It is actually a recombinant BNP. So it's a substitute BNP. Recombinant means they make it in the lab. So that's one of our body's natural responses. If that heart's getting stretched because we're in fluid overload, we release that BNP because it's supposed to help improve the pumping action of the heart and help get rid of some of that fluid. So, if we have heart failure, we can actually give them more BNP with this Nasratide. So it's going to help improve their functioning of their heart. Dilates the arterial and venous blood vessels. So it decreases both preload some benzos.
We'll get a Ativan or Valium.
Distraction imagery. The morphine. So our treatment goals. With chronic heart failure, similar to with acute, treat the underlying cause, contributing factors, ACE inhibitors like Capitan or Captopril, they can cause hypotension. So when our patient is put on an ACE inhibitor, or if they're taking an ACE inhibitor, we want them to call for assistance to go to the bathroom. Because we don't want them to get up and crack their head open or fracture their head. Our ACE inhibitors are also potassium sparing. So we do not want them to increase the potassium in their diet. The next thing they come in with potassium of 7. And ACE inhibitors actually should be taken 1 hour before meals. Their heart failure is actually related to hypertension. their sodium intake. Fresh fruits and vegetables are good options. Your frozen fruits and vegetables normally have lower sodium than your canned veggies do. Canned soup, high in sodium. Lunch meat, hot dogs. Your frozen dinners, frozen pizzas, all high in sodium. And another thing a lot of people don't realize, dairy products. Your milk, even if it's skim milk, high in sodium. Your cheese, your ice cream, those are high in sodium. Frozen normally have lower sodium than your canned, but they're making a lot of our canned vegetables with lower sodium. And they actually say if you rinse those vegetables, dump out the fluid that's in them and rinse them in the sink with a lot of water, that actually will flush some of the sodium out. But typically, most of your frozen veggies, unless you go to the frozen veggies like the Green Giant has that comes with its cheese sauce and this kind of sauce and that kind of sauce, then your sodium goes through the roof. But if it's just the straight frozen veggies, they normally have low sodium. But normally all your boxed dinners too, mac and cheese, or the hamburger helpers and all those, they have high sodium. So you're better to you can still have it, but buy your own pasta and everything and make it yourself. It's more work. It's not more work. But the long run it pays off. So remember, dairy products, high sodium. Veggies are low, fruits are low. What about eggs? If you look at the sodium of eggs, with eggs, right? So your eggs are actually low sodium. As long as you're coming out of the shell. The thing we worry about with eggs is the cholesterol in them. But our patient with heart failure, they could eat an egg. As long as they don't salt it as they're cooking it. Or when they're done cooking it. And don't put cheese on it. But eggs actually are low in sodium. So an egg would be okay. Well, you can get unsalted butter. Actually, I would tell them to stay away from the fried eggs. Period. And have more, like scrambled or something. But no milk added to your scrambled eggs. So I would try to get them to cook it with something that had a skinny chocolate. Hard-boiled egg would be fine. Or a poached egg. As long as they're not done with the salt on it. So eggs would be okay. Dairy products, high sodium. I know there's a couple nutrition, at least one nutrition thing. You guys notoriously bad on. And we do want to limit eggs when we're looking at our coronary artery disease because of the cholesterol. But we do want our patient, eggs are actually a good source of protein too. So you'll see when we get to renal failure, we'll mention eggs again as okay for our renal patient. They're actually a complete protein that they can eat. Mrs. Dash has like, I don't know how many different varieties. You can go to the store and they've got, you know, like this much of the shelf that have all these different Mrs. Dashes on it. And this blend and that blend and this blend, and it's like, oh my gosh. All I know is the Mrs. Dash I got home, I don't like. So I just go with that.
Hey, I've got some trouble with it. The sea salt and everything, is that supposed to be better for you than regular salt, or does it just fall the same line?
It depends on what source you look at. Some of your sources say you can use less sea salt and you get a saltier taste. So even so they're saying that the taste of your sea salt is more tart, more potent, so you can actually use less of it. And supposedly it's healthier than our other salt. Doesn't have iodine in it, so if iodine is a concern.
That's my husband's, you know what, I have to come out of that.
Well, and iodine is present in other things as well.
Yeah.
But the most common source of our iodine is through our salt. But even with that, you know, with the amount of salt we take in, we can still reduce our salt intake and get another yeah, so the use of sea salt, it depends on what source you look at. You know, it's kind of like when you start looking at all your diet plans and, this plan is a no-carb diet, you're eating all those proteins. Well, that may be good for this one little group of people. But the problem with being on that high-protein diet is if you have any issues with your kidneys at all, you could completely shut them down and end up in kidney failure. Because proteins, when they're digested, those molecules are actually bigger than some of the other molecules, and when they get down to the kidneys, where the kidneys filter them out, kidneys have to work harder. And if you already have kidneys that are working harder to start with, then that type of diet can totally shoot up. But actually, from all the sources I have read, they actually, from everything I have looked at, they actually say that one of the best diet plans to follow is actually the DASH diet. Because it outlines, your specific, how many servings of your grains, how many servings of your fruits and veggies, how many servings of lean protein that you get, and it reduces your sodium. That it's overall, when you look at your nutritional needs, it is one of the healthiest dietary plans that's out there. Fluid restriction. Patients may have it, they may not. But it depends on the severity of their condition. But we do want them to weigh themselves. Here again, weight gain, 3 pounds over 2 days, or 3 to 5 over a week. I want you to remember 3 pounds over 2 days. It needs to be reported. We need to evaluate that patient for other signs of acute decompensated heart failure if they've got that weight gain. Nursing management. We're going to do our assessment, collect our subjective and objective data. We're going to come up with nursing diagnoses. We manage your meds at home? Nursing home has bad? Let's copy in there. Let's set them up with a home agency, see what we can do to make it in their home. You know, your family might say, tired of taking care of it. That's why my cousin saying me and my crazy cats, I'm tired of dealing with your mom. You're going to the home. So fine, as long as I can take my cats. But let's refer them to a home agency first to help with those medications. Acute interventions are going to be needed when they have exacerbations, when they go into their acute decompensated heart failure. And we're going to manage their symptoms, daily weight, salt restrictions, conserve energy, support systems. Ambulatory and home care, well, love teaching. Let's make sure they know why we're doing what we're doing. Let's help them adapt. Let's get their family involved so family knows why they can't take. Grab and go. Let us stay there and feed them the corn dogs and the popcorn and the deep fried Twinkies and the fresh milk that you just milk from the cow. Hey, Twinkies are coming down. Not that I eat. Medications most likely are going to be lifelong. They'll need to know when to take them, when not to, how to check their pulse, what they should do if their pulse is low. Their pulse is low. Call their physician to find out if they should take it or not. We don't want to tell them, never take it if your heart rate's less than 60. That's the wrong answer. We're going to have a call. Call the healthcare provider if your heart rate's less than 60 before you take your medicine. And then they will tell you whether you should take it or not. Maybe they get a pulse of 58. So they call their doctor. They're supposed to take this morning. A lot of times the doctor's going to say, oh, you haven't taken it. Or their heart rate's 58 and they're supposed to take blood pressure. Most commonly the physician's going to say, go ahead and take it. You know, I took care of a little lady. Hayes took care of her. She was one of our frequent flyers. She was in and out because she had heart failure. This little bitty thing, maybe weighed all of 8 pounds. We were lucky if she had a pressure of 80 on a good day. So, you know, being the good nurses we were when we go in to give her her meds in the morning, check her blood pressure, 82. Over 40. Heart rate 60. She's pink, warm, dry, talking to us, not having a problem in the world. And we're all going, oh. So, back to the desk we go. We're on another doctor. Give her meds. She needs them to keep her heart going. I don't care what her pressure is. Finally, he wrote his own word. Do not hold meds unless her pressure is less than 60. So, based on a lot of different things. They're gonna look at your lifestyle, they're gonna look at your age, they're gonna look at what other problems do you have with your health, what, meds you're on, do you have a support system? They look at all kinds of things when they look at that. And you're placed on a list. So I have this coach thing on the side, I have that highlighted, and then I have candidacy based on many things starred. So they look at a lot of different things when we're looking at, do you get a heart transplant? You can wait for a transplant at home, you can wait for a transplant in the hospital, depending on what the condition is. Waiting period is long. Many people die. They're waiting for a heart. They actually, when they do the surgery, they remove the recipient's heart, except for the posterior right arterial walls and their venous connections. It's placed within the donor's heart. And the donor SA node is preserved so that a sinus rhythm can be achieved postoperatively. They start immunosuppressant therapy already in the operating room. Infection is a big concern. Second complication, rejection. And then they say beyond the first year, malignancy and coronary artery disease are major causes of death. So even if they give you a new heart because it's coronary artery disease, you can develop coronary artery disease. Yes, there was, I can't remember, but a person died and they did not realize when he died that it was because of rabies. He was an organ donor and donated organs, and now I don't remember how many. I know one for sure. One person. That was the second one. So I was gonna say, I couldn't remember what the news said, but they're still trying to track down all the people that received donations from him, because the people that received donor tissue and organs from him have been exposed to rabies because he actually died from rabies. And now one of the patients that received a transplant from this person has died, and I think this was the second death related to those transplanted organs. And, periodically you'll hear of things like that happening. There was actually a funeral home on the East Coast that was illegally harvesting bones from the bodies they were supposed to be embalming and burying. They would take the bones out and replace them with PVC pipe, because you can't let the family know you took their loved one's femurs. So they took PVC pipe in there, and then they forged the documents, got them into the organ donor network, and we have these untested bones out there being transplanted into people. They got caught because they had somebody who would have needed an extra long casket because they were very tall, and the family couldn't figure out why they didn't get billed, why they had a regular sized coffin when he should have needed this extra long coffin. And then it was found out that this is what they did, so they just shortened his leg, and he put as much PVC pipe in it and a regular sized coffin. Yeah, don't give it to PVC pipe. But the sad part about it, there was actually one person here in Iowa that received from one of these unchecked ones. They can't go in and remove it. It was used in a spinal fusion. So now this person has to periodically undergo testing to see if she's developed any bloodborne disorders, like HIV, hepatitis, all of those kind of things, because that bone wasn't tested. And they could have bone cancer. You know, a lot of diseases could be transmitted like this. Yes. They actually do endometrial biopsies to evaluate for rejection. And they'll go in, like they're putting in a subclavian catheter, and they'll insert a little tool in there and just snip off a little piece and pull it out and test it. Weekly for the first month, monthly for the following 6 months, yearly thereafter. There's also what they call a Hertz breath test that they can do, and I can't tell you what that all entails at this point. We monitor the T lymphocytes, and care is focused on promoting adaptation, monitoring their cardiac function. You know, they still have to make lifestyle changes and teaching. You know, I mentioned yesterday, these are the people that think maybe they aren't going to love their family anymore after they get that new heart, because we always think of all of our emotions being centered in our heart. Or they'll get that heart and they will have troubles adjusting because they know somebody else died so I could live. Or they think, this isn't my heart, this is somebody else's heart. And just that thought always going through there, somebody else's heart is pumping in my body, and now who am I going to love because somebody else's heart is here? And sometimes it actually make them mentally ill because of that. And they do get something. And sometimes you'll see it periodically, they'll do stories on the news about those organ recipients who were able to meet their donors' families. And they're able, and sometimes they need that to, you know, be able to say thank you. And for both groups of people to be able to respond.
But isn't it true that even though your work is going on, your family has to feed you?
Yes, that is exactly true. Even if you have your driver's license marked that you're an organ donor, even though you have an organ donor card, you need to make sure your family know what your wishes are. Because if your family's standing right there and they say, no, you can't have their organs, we're done with you. We're not going to we will not take your organs, even though your card says you wanted us to. Because you're gone, you're not going to sue us. Your family will. I mean, that's part of it. That's a big part of it. Right there. But if she would have said no, they would have said, okay, not a problem, thank you for your time, and left him to proceed with you. Yeah, and no. Now, some places, some of our larger hospitals in our bigger cities, they actually have an organ specialized people to do that, because I know when I was working before, when we had a death, we would ask the family, but then if they said yes, our first job, call it a supervisor. And then she would take care of everything from there, while we finished dealing with the immediate situation. Yeah, because they have special training on how to respond to them, on how to answer questions. Yeah. Oh, everything. Worse than because they're looking for any possible exposure to anything that potentially could be given to somebody. Trigger it down. Right, they'll if they can't get another family, or they can't determine that person is in the family, and they have that mobility card, they will also Okay, so we've got to do cardiogenic shock. Because there's only like, 4 slides?
Just wanted
Most common cause of cardiogenic shock is an MI that affects the left ventricle. The heart's not pumping effectively. So we've got decreased cardiac output. So there's no decrease in our circulating volume. So we didn't lose any blood. Our heart's just damaged and can't pump it. So we have tachycardia, hypotension, narrow pulse pressure, tachypnea, pulmonary congestion, cyanosis, would shove or central line and put in a pulmonary artery catheter.
We let her like 30 minutes.
Yeah, because she needed that, with that central line removal, we can measure the right atrial pressure or the CVP pressure. But in this case, we really need to know what that wedge pressure is. Because remember that wedge pressure is a more sensitive value, gives us a better reading of our patient's fluid status. And with cardiogenic shock, that fluid balance is so important because they haven't lost fluid. But we got the low blood pressure, we got all the signs like they would have, or that makes us think that they did something. Because she was also constricted because of the low pressure. We're going to use meds. Dopamine increases myocardial contractility, the automaticity, and AV conduction. Levophed. I talked about Levophed yesterday.
Can you bring your head again?
So we'll use dopamine or the Levophed. And Levophed is another agent that's going to cause vasoconstriction and bring up the blood pressure. And yesterday I talked about it. If we are on Levophed, we ought to be monitoring that SVR. If the SVR is elevated when they're on that vasoconstricting medication, that's an indication we have that dose too high. We need to back it off. We had a saying when I worked critical care, we didn't like Levophed. It was always a drug of last choice. And our saying was, we didn't have family cures. It was Levophed. Because it was one of those last ditch medications and if nothing else worked, then we went to the Levophed. And in most cases, they didn't heal. was low. And in this situation, we give that Lasix. It's going to get rid of extra fluid. The heart is going to pump more effectively. We're going to see their cardiac output is actually going to come up. Their blood pressure is actually going to come up. But if you just looked at this without me rationalizing through it with you, some of you would have never given that diuretic because their blood pressure is anything.
But I was just thinking, like, why would you give the diuretic? I understand you can put over it, but that diuretic is just gonna make the blood pressure come down in my head.
In your head, because that's what we're taught. It gets rid of fluid, we get rid of fluid, because that's normally how it works. We get rid of fluid, then our blood pressure comes down. But in this case, we have to look at what actually has caused that blood pressure to be low. And this person probably has heart failure or cardiogenic shock or something like that going on. So their heart's not pumping effectively, and because that wedge pressure is up and that cardiac output is down, we know we need to give that diuretic because it can't pump the blood out. And because it can't pump the blood out, that's what's causing our blood pressure. So remember, our pulmonary artery wedge pressure is our most sensitive reading. Look at our patient's fluid status. Remember, we went through how to calculate the stroke volume. Cardiac output divided by the heart rate. Remember, we got to make sure stroke volume is milliliters. And cardiac output is always in liters. So get your numbers the same before you calculate. Pulmonary hypertension. Is our treatment for pulmonary hypertension. So we've got elevated pressure in our pulmonary system. So if our treatment for pulmonary hypertension is effective, our pulmonary vascular resistance will decrease. So if our treatment for pulmonary hypertension is effective, our pulmonary vascular resistance will decrease. With our pressure lines, we always want to reference that transducer or stump top at the phlebostatic axis, not to the insertion site, but to the phlebostatic axis. With our arterial line, if that low pressure alarm goes on, that means something has caused our patient's blood pressure to drop. We need to go check our patient. Did they have a dysrhythmia? Did something become disconnected? Oh, okay, so like here we had a cardiac output of 3. get by 130. And I can't tell you what that works out to be. But then you get milliliters per minute. So that's how much blood is being pumped out with each heartbeat. I believe it, I would say so. Paper test, yes, we have 65 questions. Now remember when we put in our PA catheter, we have to have our patient on the cardiac monitor. We've got to have our PA catheter hooked up to the monitor because we got to watch the waveform. During insertion, when we get the pulmonary artery wedge pressure tracing, that means our catheter's in the right spot. And then we're going to verify it with chest x-ray. What if they put that in and afterwards our patient complains of shortness of breath and we don't hear lung sounds on one side? Yeah, let's call the doctor. I didn't mention it, but it's, when they're putting in a subclavian line, there's always a risk they can puncture a lung. Same thing is true when they're putting that pulmonary artery catheter in. So let's make sure we assess our patient's respiratory status. And also we gotta watch that monitor because they could have dysrhythmias when we put it in. What if that catheter spontaneously wedges? What are we gonna do? Call the doctor. Yeah, better let you up this a little bit.
I hope you enjoyed this as much as I did. Say love you.